Welcome to the University of Washington Internal Medicine training video for the use of point-of-care ultrasound for bedside paracentesis. This video will describe the use of ultrasound in performing this procedure, and the technique for the procedure itself is covered in the following modules. At the end of this module, the learner should be able to describe the advantages and risks of using ultrasound for paracentesis, position the patient for optimal fluid visualization, choose the appropriate probe and machine settings, and enter patient information prior to examination. Demonstrate knowledge of surface anatomy. Identify surface vasculature and intra-abdominal organs and fluid. Choose an appropriate needle insertion site. And identify situations in which bedside paracentesis is not appropriate and the procedure should be referred to radiology. Compared to traditional physical exam-guided paracentesis, the use of ultrasound has several advantages. It is more sensitive and specific for the presence of ascites, especially for smaller pockets or in patients with complex anatomy. Published studies suggest that ultrasound improves procedure success rate and decreases adverse events and hospital costs. The risks of bedside ultrasound for paracentesis are mostly associated with over-reliance on or misuse of the technology. Remember anatomic landmarks and interpret images properly to avoid complications. Avoid overconfidence and only attempt sampling ascites pockets of adequate size. Finally, avoid paying too much attention to the screen image and inadequate attention to proper technique, such as needle placement and the angle of needle entry into the abdominal cavity. Positioning for paracentesis is important. The patient should be supine. Placing pillows under the patient's flank, contralateral to the side of needle entry, and elevating the head of bed 30 degrees can help optimize the size of the visualized fluid pocket by shifting fluid into the planned area of needle entry. Patient information should be entered before each procedure. On this machine, for example, select Patient. If a previous patient's data appears on the screen, select New/End. Then enter your patient's initials or other identifying data. This screen also allows you to choose procedure type. Select Abdomen from the drop-down menu. When choosing your probe for bedside ultrasound, remember that the linear probe has a rectangular footprint and a higher frequency, and is the probe of choice for identifying pertinent abdominal vasculature prior to paracentesis. A lower frequency probe, either a phased array as shown here or a curvilinear probe, is used to examine the intra-abdominal organs and assess for acidic fluid. The phased array probe has a square footprint. As opposed to the rectangular image created by the linear probe, the phased array probe creates a cone-shaped image as shown. With either type, the dot on the transducer should point to the patient's right side. This corresponds to the dot on the left of the ultrasound screen. When performing paracentesis, the left lower quadrant is often preferred due to a thinner abdominal wall in this region, less risk of surgical scar or adhesion, and the possible presence of a gas-filled cecum on the right. Identify the spleen and the lateral rectus sheath, along the edge of which run the inferior epigastric arteries. On the patient's right, identify the liver and lateral rectus sheath. If ultrasound is not available, many providers identify a spot 3 cm or 2 finger breadths cephalad and 3 cm medial to the anterior superior iliac spine. Using ultrasound, we can see that this is actually not an optimal location for this patient, with a deeper pocket of ascites visualized by moving medially and cephalad. This is one of the advantages of using ultrasound for paracentesis. Use the linear probe to confirm the absence of vasculature in the planned area of paracentesis. Here, color Doppler is used to aid in this evaluation. On this ultrasound machine, select the button for Color from the main screen. Use the trackpad and button below the ultrasound screen to adjust the size of the Doppler window. If possible, identify the inferior epigastric artery along the edge of the lateral rectus sheath. At a minimum, you should examine the area of proposed needle entry. Note that a color Doppler signal will not appear when the probe is perpendicular to flow, and so this evaluation must be performed with the transducer at an oblique angle. When the transducer is perpendicular to the flow of blood, no color Doppler signal is shown on the screen and the vessel cannot be visualized. When tilted oblique to flow, a vessel can clearly be seen, overlaying the site of possible paracentesis. Proper use of color Doppler technique prior to paracentesis can help avoid inadvertent vascular injury and potentially serious subcutaneous bleeding. After scanning for vessels, identify the liver or spleen, depending on the site of entry, characterized by their dense, echogenic, and homogeneous appearance. Here, the spleen can be seen in the left upper quadrant. In patients with hepatosplenomegaly, these organs can often be found lower in the abdomen than expected, and one advantage of ultrasound is the ability to locate and avoid these structures. Additionally, one can measure subcutaneous tissue depth using ultrasound. Each dot on the right side of the screen corresponds to 1 centimeter. This patient has just under 2 centimeters of subcutaneous tissue above his ascites. This can be used to estimate how far you should need to insert the needle prior to fluid return, as well as how large of a pocket is present. When present, ascites appears as anechoic fluid with bowel floating in it. It is important to press and visualize bowel behind the ascites, and make sure that this is not a dilated, fluid-filled loop of bowel or bladder, rather than a pocket of ascites. Ascites that is localized to areas near visceral organs, or not large enough to be assessed safely at the bedside, should be sent to radiology. This video shows a small amount of ascites surrounding the liver. This could not be safely attempted at the bedside. Similarly, ascites that is complicated in appearance, with loculations or abnormal structures present, should be referred to our colleagues in radiology. This video shows mucinous ascites, with complex appearing fluid surrounding visceral organs. This slide shows complicated ascites, with a mass found adjacent to complex fluid. Doppler shows large vascular structures within the mass. Attempting this paracentesis at the bedside could have disastrous consequences. Finally, once ascites has been assessed and abdominal anatomy defined, the site of needle entry should be selected, as described earlier. Paracentesis using bedside ultrasound can be done using dynamic technique, direct needle visualization, or static technique, marking with ultrasound and then performing without direct visualization. Radiology often performs the procedure using dynamic technique, whereas at the bedside, static technique is most often used. One important point when performing static technique is to pay attention that the needle be inserted in the same direction that the ultrasound was facing when bedside ultrasound was performed. One can see in the accompanying figure how easy it can be to misdirect the needle and end up in an area of abdomen that was not visualized by ultrasound. In summary, ultrasound guidance for paracentesis provides information that is not gained by physical exam alone. It likely reduces adverse events and failed procedures, or dry taps, when used correctly, and reduces expenses and avoids the transport of unstable patients compared with having radiology mark the location. The correct use of ultrasound for paracentesis, however, depends on a solid understanding of the surface and ultrasonographic anatomy involved, and sound clinical judgment about when to refer complicated cases to radiology. Thank you for watching this module.